to the APSC Club Forum in Cardiovascular Disease. I'm Dr. Yenn-Jiang from Taipei, Taiwan. So it's my honor to welcome you to this important symposium hosted by Asia Pacific Society of Cardiology, and focus on the critical issue, prevention of sudden cardiac death in structural and non-structural heart disease, risk stratification, and targeted therapy. We know that the sudden cardiac death is a very important and catastrophic disorder and very difficult to treat and prevent. So with the progress of the genetic disease, imaging technique, and device engineering, currently, I think the cardiologists will be able to treat and prevent sudden cardiac death. And I think currently the risk prediction and prevention of sudden cardiac death in ACA, acute coronary syndrome, and late coronary disease, and also in patients with dilated cardiomyopathy. I think, and also in the primary electoral disease for Asia Pacific, the patient. So today we have esteemed panels from experts and from Mongolia, Pakistan, and Japan, India, and Thailand will share their invaluable insight and present the latest update and perspective. So I'm Dr. Yenn-Jiang, and also like to chair the session of today. So thank you very much, and welcome you to participate, the delegate, the field in this important symposium, the field of cardiology, and we will start the symposium. First of all, I like on behalf of APSC, so I like to have the following information for you, the disclaimer. So first of all, I like to mention that the content of the webinar is copyrighted by APSC and should not be distributed without the prior permission of APSC. And the view and option expressed by the webinar are those with faculty member and not necessary to present of those of APSC. And the live stream content of the webinar will be made available in the cloud at APSC and Facebook and YouTube page. And thank you. So let us start the symposium today. So let us welcome our first speaker. So the first speaker is from Mongolia, and Professor Munkhtulga Gantulga, who is currently he's from the National Cardiovascular Center, third state of hospital from Mongolia, and the interventional cardiology in the coronary care unit. And today he will give us a talk, the risk stratification and prevention of sudden cardiac death in acute coronary syndrome, early and late after infarction. So let's welcome. Let us welcome Doctor.
So thank you for the invitation. So hello everyone. I am Dr. Munkhtulga Gantulga from Mongolia, and my today's topic is risk stratification and prevention of sudden cardiac death after acute myocardial infarction. So there are two main types of causes of death following acute myocardial infarction. First one is non-arrhythmic causes, and the second one is arrhythmic causes. So non-arrhythmic causes are, as we know, that it is mostly due to the mechanical complications of acute myocardial infarction, like ventricular or papillary muscle rupture, precardial tamponade, septal defects, and ischemic valvular dysfunction, mostly due to mitral regurgitation and recurrent infarction. These second types of groups of causes of death following acute myocardial infarction is arrhythmia, life-threatening arrhythmia like VT or VF. So there are some relationship between the time course after acute myocardial infarction and the causes of death. So in first month, mostly myocardial infarction or the mechanical complications of acute MI mostly happened in the first month, but the following 3 months, the arrhythmic death incidents are increasing day by day or month by month following acute myocardial infarction. The Valiant trial says that. So there are many trials and studies conducted through this topic, and the most famous are the MAST trial and Dynamite trials are the most biggest one in this field. So as MAST trial very firstly said that they gives the clue the overall survival benefit. Maybe survival benefit is, it gives survival benefit with electrophysiologic study guided ICT implantation. So these trials are studied ICT implantation only within the 40 days after acute myocardial infarction. So just meaningfully less than 1 month after acute myocardial infarction. So, but the MAST trial has a kind of limitations, bigger limitations, and the study participants are only 56 patients enrolled in this trial, and the most of patients not on the beta blockers. So that's why it's not, its result is not implemented to the practice. So next one is the Dynamite trial that also it studied ICT implantation within the 40-day, and the patients received ICT implantation with the ejection fraction less than 35% and autonomic dysfunction, but the result was not survival benefit. Okay. So I would like to mention the Valiant trial that acute myocardial infarction, the risk of sudden death greatest in the first month and declines thereafter, the following time course. And the most patients are less than ejection fraction, 30% are especially high risk for sudden death. It realized that, and but even though the patients with higher ejection fraction are still at the increased risk, but not as much as the severe reduced ejection fraction patients. So that's why this data will help us to target the preventive strategies to those at highest risk. So in this table shows us the difference between the death from the other cause and death from the cardiac death, and the difference between these two, and age, male sex, and some clinical measurements, and also the medication usage are different in other death group and cardiac arrest group. So in this table, the most patients death in the first 30 days after acute myocardial infarction, but still the following days, sudden cardiac deaths incidence quite not low during the next months. So concluding this study that mostly severely reduced ejection fraction patients are in these patients groups, the mortality is very high, especially in the very first month after acute myocardial infarction, but still it's higher than the other groups in very first year after acute myocardial infarction. So in this group, that patients need some preventing strategies. So what's the underlying mechanisms of sudden death after myocardial infarction? As we know that following first attempt of myocardial infarction, the healing and remodeling process started happening in the myocardium. And within the first month, or especially first 2 weeks, then there were inflammation processes are very actively ongoing. And after 1 month, the fibrous scar formed, and then it shifted to the chronic inflammation process and reverse remodeling of the left ventricle and the myocardium. So according to these pathologic remodeling processes, it gives some underlying mechanism clue to why the patients suddenly die. So autopsy-based trials, also it is the line trial, then it studied 105 deaths. Those are classified as sudden cardiac death, and autopsy suggested that almost 12% of patients are attributable to cardiac rupture, and 3.8% the patients died due to the pump failure, and almost 30% of the patients died due to the recurrent myocardial infarction. So most study shows the results as same as the biggest reason of the sudden cardiac death following acute myocardial infarction is recurrent myocardial infarction. So deaths in the first month after infarction were more likely to be mechanical, with the risk of arrhythmic death becoming more predominant after at least 1 month or the several months. So the next trial is optimal trial that these investigators also found out that 55% of deaths are classified clinically as sudden death, but this study does not classify the further investigate the sudden deaths, just like the line trial. Is it really arrhythmic death or cardiac rupture, etc.? The main mechanism underlying the arrhythmic death is reentrant tachycardia due to the scar formation. In acute phase after infarction, the ventricular arrhythmia can develop as a result of changes in cellular electrical activity, particularly repolarization problems and also refractory periods. And after 5 days later, the most myocytes within the infarct core have died and leaving the subendocardial layer of the border zone of surviving myocytes, and cells in both infarction or necrotic zone and the border zone they have prolonged refractory periods. The resultant regions of slow conduction or conduction block allows the reentrant circuits to develop the reentrant tachyarrhythmias. So that's why the multi-scars gives multi-reentrant circuits, then it gives more risk to ventricular arrhythmia development. Also, in this trial, it is kind of interesting study that the study investigators studied the 8 days after acute myocardial infarction. They investigated the EP study, and they 3 days and 8 days and 10 days they do the EP study. And interestingly, the 8 days of VT inducibility is same as the 100 days after acute myocardial infarctions VT inducibility. So if we it gives the clue that if we do EP study at the 8th day after acute myocardial infarction, then it gives some prediction after acute myocardial infarction and VT or VF development after acute myocardial infarction. So also there is some question we need, that is there any non-invasive risk stratification tests? And those are studied. Then the QRS duration, heart rate variability, and microvolt wave alternance and single average DCGs are maybe the risk stratification tests they are. So the many studies conducted these questions, and ejection fraction is during the very first acute phases of after acute myocardial infarction, it does not give any survival benefit. But after 1 month, the ejection fraction gives the survival benefit, especially in patients with less than 30%, as we know that. Also, it is in the guideline. And electrophysiological study, microwatt T-wave alternance and heart rate variability, sinus average DCG, course duration, and non-sustained VT, those are not gives the prediction of survival benefit in the early phase after acute myocardial infarction. But only 4 randomized ICD trials conducted and tested these results, and non-sustained VT and sinus average DCG, and also EP study maybe gives the survival benefit if investigate according in the correct way. Also, the coming study field is cardiac MRI researches that infarct size may be predictive of arrhythmia, even regardless of the acute or chronic phases after acute myocardial infarction. It maybe predicts the arrhythmic deaths after acute myocardial infarction. But the cardiac MRI-based studies, not the bigger trials are conducted and not published yet, so we cannot say at that moment. So non-invasive markers like autonomic dysfunction have proved to be unsuccessful in selecting patients for early defibrillator implantation. And also cardiac MRI, with its ability to detect scar size very correctly, and then tissue heterogeneity, has emerging promise for early risk stratification, but larger studies are needed in this field. So EP study testing has a randomized evidence as an effective test to guide ICD therapy. However, its utility early after acute myocardial infarction has been only in the observational studies. So also the clinical trials and larger studies are needed in related to the EP study trials. So how can we, the next topic is how can we stratify the risks of the patients, the patients die or not after acute myocardial infarction event. So the MAST trial tried to stratify these patients, and the risk stratification variables are shown in this slide. And according to the variables, we should give the points. And after the study conduction, the 2-year survival event rate was started with the score of around 50 to 60. It gives the survival difference between the total mortality and the arrhythmic death, cardiac arrest death. So maybe this kind of risk stratification test is maybe come to us in clinical practice to prevent this sudden cardiac death. Also, in MADIT second trial, every patient benefits from the ICD. Then the MADIT 2 second trial gives the answer to this question that with no risk patient and with high risk patients, there are no difference between ICD and conventional treatment groups. But the moderate risk patients, like 1 or 2 or 3 or more risk patients the benefits from the ICD treatment, but not very high risk. But in this study, in very high risk patient groups, most of patients had severe kidney dysfunction. So that's why it does not adjusted the kidney dysfunction patients in both groups. So in a dynamic trial, it tested the ICD implantation in very early after acute myocardial infarction, and implanting the ICD in just after acute myocardial infarction or within the first month, it does not give. There is no difference between survival benefits in the ICD or control groups. But in dynamic groups, the in the very first ICD implantation in the very first after acute myocardial infarction gives the survival benefit, but within the first month, then it does not give, or there is no difference between these two groups. So the proven medical preventions are beta blockers, AC inhibitor or angiotensin receptor blockers, or aldosterone receptor antagonists decreases the early sudden cardiac death and also all-cause mortality. But antiarrhythmic drugs like amiodarone, cetolol, or classic 1C class antiarrhythmic medications, it does not decrease sudden cardiac death incidence, or it does not have any effect in all-cause mortality. So we have a MADET first and MADET second trials, and recently the MADET second trial, if we implant the ICD after 1 month after the acute myocardial infarction, it gives survival benefit. So that is why I would like to conclude my presentation that ICD is not beneficial in early after acute myocardial infarction or first 30 days after acute myocardial infarction, regardless of left ventricular ejection fraction. But ICD is beneficial only 30 days after acute myocardial infarction and the patients with ejection fraction less than 35%. So the today only known risk prediction is ejection fraction, but the promising risk stratification measurements are coming to our clinical practice, but not larger clinical trials conducted and published yet. And also these 3 groups of medications are only proven medications that decreases all-cause and arrhythmic death after acute myocardial infarction. Okay, thank you for your attention.
Okay, thank you very much, Dr. Monktulga, for your very nice and comprehensive talk with regarding the sudden cardiac death risk stratification in patients with acute myocardial infarction. Thank you very much. So I think you have mentioned that, of course, the risk stratification in patients with acute myocardial infarction is very important. And also, currently, the primary prevention in patients in the acute phase, less than 30 days. So the primary prevention of ICD may not be so effective as shown in the MEDIT or MAST trial. This may not include the AMI case. So you mentioned that some medication may be helpful, but the ICD may be equivocal, right? Yeah. So do you have I just a quick question? Do you have any? And also you mentioned that in acute phase, less than 30 days, maybe a structural change must be important. Structure like the rupture, cardiac rupture, but after 30 days, the arrhythmia is even more important. So you say there's no gold standard for ICD implantation. So do you recommend that only use the medication, or is any other strategy to prevent sudden cardiac death? Because you mentioned that in patients with acute myocardial infarction, the early phase, the incidence of the arrhythmia still remain very high, right? So ICD is equivocal, but is there any role of the medication or the catheter ablation in the field and in the acute phase?
So in acute phases, also the Valiant trial gives the answer that mostly mortality is happens due to the mechanical or the heart failure complications. So that's why in these acute phases, the medications first. So after at least 30 days, the fibrotic scars formed in the myocardium. So that's why at that moment, we should start to consider the ICD implantation or the secondary prevention other methods.
Okay, thank you. So you mentioned that the ICD primary prevention is equivocal. Currently, there is no evidence for the primary prevention. So the alternative therapy like the medication would be important. Like our panel just mentioned that a very typical challenge for patient with just survivor for the acute myocardial infarction, but less than 30 days, but still have a myocardial infarction where they have a ventricular arrhythmia, maybe less than 30 days, but still have arrhythmia. Then we sometimes we have difficulty to treat this patient. Yeah, so I think that medication is very important, like the beta blocker and other medication could be useful and to prevent this. And I also like I'd like to mention that in some series that the medication and currently there's some catheter ablation remain to be an alternative choice, the therapy in addition to the ICD implantation. But currently, I think conservative therapy will be much more important. So currently, we mentioned that currently the ICD implantation is only recommended, primary prevention is recommended only the 40 days after the myocardial infarction. So you just mentioned that after 30 days may have a benefit. So do you consider that the ICD implantation guideline the date should be put earlier to revise in current days institute situation from the evidence? Do you have any idea or comment?
So do you mean that do I recommend ICD before the 40 days?
Yes.
Just following acute myocardial infarction? No, I just followed the guideline, and I do not recommend ICD implantation just after acute myocardial infarction or within the first month. I do not recommend.
Yeah. Okay, thank you. So, okay, thank you very much for your nice talk. Currently, thank you. So we'll move to our next talk.
One question on the chat box.
Yeah. Okay. Yeah. So I think currently we have mentioned we have a question from the audience that so who will have a question?
Hi, Dr.
Okay.
Ashish Nabar here.
Yes.
Can I ask a question?
Yes. Okay.
Yeah, Dr. Monktulga, I enjoyed your talk and a very comprehensive review on the subject. My question, as I put on the chat box, is: you have a patient with an acute myocardial infarction who has undergone a primary angioplasty, has been completely revascularized. On day 4, he gets a sustained monomorphic VT. He is not in left ventricular failure. He is not on inotropes, and you had to shock him out of the monomorphic VT. Now, one of the limitation in your discussion to not recommend ICD in first 40 days is the cause of non-arrhythmic deaths is higher in this time, and so you would probably not derive the benefit of ICD. But here is a situation where the patient is not on inotropes, is not in left ventricular failure, and was to be shifted out of the ICU, say today evening or tomorrow, and he gets a VT. I fail to understand how you can withhold an ICD from a patient if his ejection fraction is, say, 30%. I just wanted to bring it up for discussion as to what do the people on the panel have thoughts about this scenario. of course, all in the context of time. Yeah.
Thank you for your question. And as a ICU and CCU doctors, it is always challenge to us, and it's very always hard to manage these patients. But there are two scenarios. The first one is arrhythmic storm. So in these patients, we just consider these patients not follows the guideline. The arrhythmic storm, patients with arrhythmic storm is requires very distinct management. So according to the latest studies, that catheter ablation must be indicated in these patients, like especially in arrhythmic storm patients, regardless of the time course after acute myocardial infarction, and it gives survival benefits, but not larger trials published yet, but the observational studies almost 100% recommend and support the catheter ablation in these patient groups. But in monomorphic wheaty patients, in my practice, we usually manage that patients medically, not implantation or ICT, etc. Mm-hmm. Also, catheter ablation is kind of one choice. Yeah.
Yeah. So I think this is a very tough. I think this is a very tough question. These are in real world. In patient with acute MI less than 30 days, you just mentioned that maybe ICT is not routinely performed for prophylaxis, but I think that before the implantation of ICT, so we have to optimize the medical therapy. For example, your electric stone, an alternative choice would be the catheter ablation to treat this patient. Of course, the important thing is that we have to make sure that the vessel there's no correctable structural heart disease like the vessel. Okay, this is a very important thing to do. So I think this is a very, very difficult task and we can face in the real world. Thank you. Okay, so we have to move forward. Let us introduce the second speaker. So the Dr. Mahesh Kumar Batra from Pakistan. He's a associate professor in the international cardiologist in the National Institute of Cardiovascular Disease in Karachi, Pakistan. Today, he will give us a talk, risk mitigation and prevention of sudden cardiac death in chronic coronary syndrome, LV ejection fraction and beyond. Let us welcome Dr. Ashish.
Thank you, everyone,
yes.
for your nice, generous introduction and inviting me to part of this your cloud webinar. Just I'm sharing my screen. Okay, can you see my screen right now?
Okay, no problem. Go ahead. Thank you.
Okay, thank you. Dr. Mongolia has done half our work. Actually, he has discussed so many trials regarding the prevention of sudden cardiac death. I think it has left me only to discuss the risk stratification now, I think so. Okay, ever since we know the topic that has been given to me is the risk stratification and prevention of cardiac death in patients who present with the chronic coronary syndrome. So I don't have any conflict of interest with this presentation, with this talk. So before the 2019, we all know those patients who present with the chest pain, either they have been classified having the stable ischemic heart disease or having unstable ischemic heart disease. But after 2019 in European Society of Cardiology guideline, so they have brought a new terminology, that is the chronic coronary syndrome, that has involved a heterogeneous group of the people that may have obstructive or non-obstructive coronary artery disease, that may be revascularized or non-revascularized, that was having the LVEF normal or below normal. So there are so many spectrum or wide spectrum of the patients that has brought into the category of CCS. And we all know coronary artery disease is a dynamic process that is characterized by atherosclerotic plaque formation in epicardial coronary artery, and it has progressively started to involve the artery before the adolescence. So the ESC 2019, it has categorized CCS into chronic stable asymptomatic ischemia in those patients who either presented with the prior infarction, myocardial infarction, but they are now stabilized, or prior coronary revascularized and now stabilized. And there are certain conditions who are present with the typical chest pain, but on their angiogram is normal. They have a non-obstructive coronary artery disease. So the same has been now duplicated, or I can say more been elaborated in the new latest guideline of AHA, American Society of American Heart Association. It has now categorized into the 5 different subgroup of the people that do present with the chest pain, and they are labeled as a chronic coronary syndrome people. So natural history of the CCS varies. It depends upon the number of the events occurring in between the stable ischemic heart disease. If there's a more frequent number of the events are occurring, and that is secondary, especially to the accumulation of the risk factors. If we decrease or treat, or we decrease the risk factors, so the progression of the disease decreases. If we do not control our risk factors, and it will start on having a SCS frequent episode of the acute coronary syndromes, the progression of atherosclerosis plaques varies very fast. So in 2019, it has elaborated a diagnostic pathway so that how can we diagnose those patients who present with the typical chest pain, or we are assuming that patients having the chronic coronary syndrome. So the non-invasive imaging strategy, having an age, it has been given a class 1 recommendation in guidelines, that in those patients who come to the emergency or come to the OPD departments with the chronic coronary syndromes, the first priority should be given to the non-invasive investigations, and preferably likelihood, which test should be given preference. It depends upon the high likelihood of the patient having a chronic coronary syndrome, local availability of the equipment and expertise, and do the patient desire. If it definitely keeps important, and their social constraint, each and everything is part of that one. So if you see, I just highlighting my pointer so that you can see. Chronic coronary syndrome, those patients who present, they can undergo the coronary CTA. And if you find there is a disease, you can first optimize these patients on the drug therapy. If they persist having the ongoing symptoms, then you can go for an invasive strategy. The preference, but should be given to the non-invasive strategy first. Every patient who present to the hospitals with the chronic coronary syndrome, they should be risk stratified. It is always imperative to risk stratify these patients so that you can provide a strategic management, either to manage them medically, either to provide them revascularization therapy. It's important that you must be knowing exactly at what risk they are. So apart from only relying on the invasive study, there are so steps that you need a clinical evaluation, history, demographics, assessment of the resting ejection fraction of a patient, and doing the non-invasive investigations, and also the invasive investigations do play a role in risk stratifying the patient. Okay. So there are so many randomized trials published. I have gone through the most of them, but have seen that not only the medical therapy, that we are insisting that medical therapy should be the first only goal, but revascularization routinely is not a good option, but definitely should be prioritized in those patients who remain symptomatic despite your GDMT. So in the recently published in this year, American Society of American Heart Association guideline on chronic coronary syndrome, they have classified as class 1 recommendation to the risk stratification, and it has been classified or validated based on the different incorporations of non-invasive, invasive, and clinical variables into either in low risk, those who are having less than 1% annual risk of having cardiovascular diseases or cardiovascular events, intermediate carry 1 to 3% risk of cardiovascular events over a year, those who are at high risk having a more than 3% annual risk of cardiovascular events. So non-invasive investigations very much varies or have a very much important that you can see over those in the center that low risk patients who are having less than 1% annual risk of MI or death, they do have no symptoms or symptoms on maximum ETT, no ischemic ECG changes on maximum ETT. They don't have stress-induced valve motion abnormalities on the non-MPI, or you can see there's no coronary. If you go for the CTA or invasive angiogram, you will see no more than 50% of stenosis, and there's no change on valve motion abnormality. Patient having a baseline defect, and they are going for the invasive or non-invasive for assessment of the risk stratification, or having a small perfusion defect or less than 5% of the heart is involved. Coronary calcium score based on the CT scoring, they may be less than 100 Agatston unit. So if you find these parameters, so you can label these patients are at low risk of having cardiovascular event, and their patients are usually managed medically and their revascularization is deferred. And second group is those patients who are at intermediate risk. These patients are initially managed medically, but if they persist and they are gone for the revascularization strategy, you can see that these patients having, if you go for the resting echocardiography, you will find that ejection fraction in these patients is between 35 to 49%. And their valve motion abnormalities having less than 2 segments or less one coronary area is involved. For coronary calcium scoring, they are very up to the 399. And if you had gone for the coronary CTA, you will find 50 to 69% of the stenosis or having 2-base coronary artery disease. And if a patient goes for the ETT assessment, having the more than 1 mm ST depression with symptoms or having a multiple segments with no LV dilation on the stretch echocardiography. So there are so many factors that should be considered while risk stratifying a patient with the coronary artery disease. Those patients who are at high risk of having coronary artery disease are those patients who are having more than 3% annual risk of death. And especially these people are those who are having ejection fraction of less than 35%. Coronary artery calcium scoring is of more than 400 units, Agatston. And when they are gone for the stress echocardiography or MPI, you will find a stress-induced LE cavity dilatation. More than 2 territories are inducible valve motion abnormalities you will find on MPI as well. And if you gone for the dobutamine stress echo, certain risk scoring strategies are also applied or scoring system to see how much at a risk. And if you go for the ETT, you will have more than 2 mm ST depression at a low workload. And if they go for the invasive coronary angiogram, you will find the left main coronary artery disease in the more than 50%. So this is actually summary I can say what I have pointed out early, that these are the non-invasive investigation tools, and these are their scoring systems that you may use them for assessment of their risk patients who are at high risk. So why and what the resting echo will, how the resting echo will help us in risk stratifying? It will help us in excluding the alternative causes of coronary artery disease or chronic angina. It will help in identifying the regional motion abnormality, which are suggestive of coronary artery disease. They will help in measurement of LV ejection fraction for risk stratification. You have already heard a great talk earlier regarding the LV ejection fraction, how much it carries a risk to the life or death, and evaluation of diastolic dysfunction. This is all you can see they have all been given the class 1 recommendation to risk stratify with the different variety of non-invasive investigations. So after risk stratifying patients, you move on to the therapy. You decide at what risk they are and what therapy should be initiated in these patients. To me, I can see that we can divide therapy based on their either non-invasive or non-pharmacological approach. And if they are not responding to the non-pharmacological approach, you can move to the pharmacology and so forth to the revascularization strategy if they are not responding to that one. So the goal of the treatment would be to reduce the cardiac death, to reduce the non-fatal MI, to halt the disease progression, to ameliorate the symptoms, and to give the more decrease the functional limitation, and overall to curtail the cost of a medical therapy. I think that is the most important thing that we should be keep in our mind while advising the therapies, because patients is already getting so many medications. So that's very much important to think about the cost as well. So in the first step of treating in these patients, patient education and shared maker decision is very much important. You should be knowing that what the patient literacy is, how much information he needs it, and what you are supposed to tell him regarding this prognosis and regarding its treatment options. Because these are the persons, if you don't properly educate them, they may not follow your commands, or they may not follow your advices, or sometimes if it has been seen in the literature that they don't comply your medications. And it is always, that's why imperative that you should have a shared maker decision, whatever type of the strategy you are choosing for him. So this is a algorithm, I can say, that has been published in recently in 2023 guidelines, and is a shared maker decision between the variety of the people, variety of experts, and so that you can have a, you can assess the cardiovascular risk, and you can involve the patient, you can involve the clinical care team, and different experts in your, you can get the help from the nutrition experts, physical experts, clinical experts, and you can detect the social determinants of health which are lying in the society, and you can get the help from the neighbors. Is very much important to get the opinions from the neighbor regarding the patient's care, patient socioeconomic status, and in this way you can build a team, because treating a patient and reducing the overall mortality or morbidity of a patient with coronary artery disease, it is always imperative to have a team. It has been shown in a variety of randomized trials and multiple observational studies that team-based approach has curtailed down to a risk or less than 15%, or decrease the risk of more than 22% of sudden cardiac death in patients who are present with the chronic coronary syndrome. So each and everyone plays its part. If nicely, the patients will decrease the chances of acquainting or the repeatedly admission to the hospital. It has been seen that these all team makers, they all what will try to do, try to risk modify these patients at each and every cost. So one of the study that I want to highlight is the Euro Action Cluster randomized trial that has demonstrated this. If there is a nurse coordinated program in the primary care that was more effective in helping out patients achieve lifestyles and risk factor goals than usual care, and it has shown that it was drastic in reducing the cardiovascular events. We have to be very much choosy or advisable regarding the nutrition to these patients, because each and every step that we are incorporating having a positive impact on the health of a patient. Recommending the treatment, especially what should patient take and what should not take, is very much important. And I think a Mediterranean diet is one of the great examples that has shown a drastic improvement in patients' overall survival if they choose it. There are though different data regarding the adaptation as well. So most of the people, they do adopt what you say, and some people, they don't follow the Mediterranean diet strictly. But definitely you have to be very much pointed regarding the nutritional status and nutritional advice. So Mediterranean diet, most of it contains vegetables, fruits, legumes, whole grains. It has replaced the sweetened foods, processed meats. I can say the sugar beverages. On the other hand, you can update the lean proteins apart from the complex carbohydrate, apart from the simple sugars. You can add the dietary fibers. The most important thing that I will highlight as the dietary sodium or saturated fat. The saturated should be less than 6% of the total caloric fat, and patients should be encouraged to add monosaturated or polyunsaturated fats in their diet, and decrease the sodium content to less than 1.5 gram is very much optimal and advisable. Another risk modifier I can say is very much important that has been shown that it will reduce the 36% mortality if the patient stops smoking. And it has been advised that any patients who present to your OPD, at every visit, you must ask about the smoking, that how much he smokes and how much and you start advising. It's a classical 5S that has been published great in 2018 in primary prevention guideline, I think so. It has been seen that it has positive impact, and you ask each and every visit, you advise to quit smoking, you assess the readiness of a patient, how much ready he is. Either he is ready to quit, it's very much important. Apart from hampering, that you tell each and every story, and at the end you will come to know that he is not willing to quit the smoking. And definitely you have to tell them what is the advantage of the quit smoking. You assist a patient with smoking by providing the different ways, either telephonic interviews or telephonic contacts. You are supposed to tell them the non-pharmacological measures of quit smoking and certain pharmacological measures, including nicotine replacement therapies, penicillin, ibuprofen, and definitely that's for nicotine chewing gum. One thing I want to highlight regarding the e-cigarette, because most of the fellows now ask me, or the patients do come to in my OPD, they ask me, sir, if I do not smoke or stop combustible smoke, do I start vaping, or vaping will help me in quitting the smoking? I always insist them, don't think that studies has shown that adoption of e-cigarettes result in overall except or decrease in or stop in smoking cessation or help in smoking cessation with the adoption of e-cigarettes, but don't recommend it, because it has not been properly studied, or safety data is still not present regarding the e-smoking, e-cigarettes. So it is always it is better that you stop in recommending it or do not recommend it. Another comorbidity that should be managed, which has a high devastating role in an overall outcome, is the blood pressure. Guidelines has seen that those patients who have gone through even 2 mm of mercury decrease in blood pressure, having a more than 10% increase in overall survival. And now guidelines has seen that those patients who have blood pressure of less than 130 and over less than 130 or less than 80, they live longer than those patients who are having a blood pressure more than 140 over 90. So it has been recommended to target that blood pressure to less than 130 or 80 by the American guidelines. And for that, non-pharmacological measures and pharmacological measures are always recommended. Initially, patients should be put on the non-pharmacological measures, weight reduction, healthy diet, especially DASH diet. A DASH diet is very much important. It would contain the less sodium and more potassium salt. Physical activity, recommending physical activity and reduction or elimination of alcohol intake. The guideline has seen that those patients who carry on drinking alcohol 1 unit or 1 pack in females or 2 pack in males is acceptable, but I insist that you discourage in taking even that small amount of alcohol, because even if you restrict that amount of alcohol, patient becomes habitual and they start taking more and more that one. Medications, AC inhibitors, ARB, beta blockers, calcium channel, ARB, AC inhibitors, beta blocker, calcium channel blocker, all are recommended based on their compelling indications or thiazide diuretics. Another group of medication that has recently been shown that though this has been innovated as a diabetic medication, but now they has been taken part in the cardiovascular medicine, and they have dramatically shown that those patients who are taking the SGLT2 inhibitor or they have been advised SGLT2 inhibitor, either they are diabetic or non-diabetic or having a heart failure with preserved EF or heart failure having reduced EF, they're having a good improvement on overall cardiovascular mortality. So still the guidelines, that's why recommended now class 1 recommendation in those patients who are having type 2 diabetes in whatever the substrate of the cardiac patients, and if patients having a heart failure, you should also advise SGLT2 inhibitors as a class 1 if their ejection fraction is less than 40%, and class 2A recommendation is their ejection fraction more than 40%, be that patients are diabetic or non-diabetic. So it's very much impressive new class of drug that has drastical role in reducing the mortality. There was the old trial. Afterward, there are so many trials have come a lot regarding the involvement or introduction of this drug. Emperors are for empagliflozin, DAPA is for dapagliflozin, DAPA-HF trial, Emperor reduce initially, Emperor preserved, deliver, so many trials, and that have shown that it has reduced the overall composite cardiovascular mortality in those patients who were prescribed these medications. So lipid management is equally important as the other class of the risk factors. So definitely you have to risk stratify the patient for advising the lipid management if their lipid content, and they have different guidelines about the lipid management, especially those patients who are at very high risk for atherosclerotic cardiovascular diseases, or I can say having a high risk for cardiovascular atherosclerotic diseases. They should be advised high intensity statin that reduces the more than 50% of LDL cholesterol to reduce the cardiovascular mass. And also guidelines enforce that those patients who are not tolerative to the high intensity statin, it is also recommended that you can start the on moderate intensity statin, which is better that even to that one. And you should go on repeating initially fasting lipid profile and monthly or within 3 months. But once you say that it has become to turn down, then you can go for the yearly investigating or repeating the fasting lipid profile to see the lipid status of a patient. And in this way, you will then stratify the patient lipids management either to start high intensity or low intensity statin. Cardiac rehabilitation having a very much positive impact in the CCS patients at reduced 15% mortality in patients who were stick to the cardiac rehabilitation programs or who have been advised cardiac rehabilitation programs. The issue with the cardiac rehabilitation was institutional or repeatedly come to the hospital. So they have also been given the programs of home cardiac rehabilitations apart from the only the institutional or I can say hospital-based cardiac rehabilitation program. Stick to that one is very much important. Initial studies have shown that up to the 12 weeks of involvement in cardiac rehabilitation have a positive impact. But now it has been shown that more and more involvement in cardiac rehab programs or for prolonged period of time in that program having a positive impact on overall outcomes. So cardiac rehabilitation programs not only it involves a wide variety of experts and it is actually one of the way of reinforcing the patient about their risk factor managements. Especially it contains the nutritionist, it contains the dietitians, diabetologists, hypertension, especially I can say lipid, especially we not need it in case for resistant cases. It says, do you have exercise trainers, exercise training, proper exercise training program, psychosocial management, and weight management, physical assessments. They all are part of the cardiac rehabilitation programs. One thing regarding the cardiac rehabilitation program was the cost. It has initially thought that it will be more costly that involve you all the different teams, but it has now seen that it is more cost effective and cost efficient as compared to not involve or use as compared to usual activities that do not involve this program, because it has seen that it has reduced the rate of hospitalization. It has reduced the number of events of acute coronary hospital admissions, unnecessary, undue hospital visits. So that's why it has been more and more unnecessary medications take those patients who are taking as usually a part, those who are not part of that program. So it has been seen that it's more cost effective and cost efficient.
Dr. Bob, please, can you close the talk short as possible? Time is up. Yeah, sorry.
Okay. Recommendation of physical activity. Patients should be physically advised of more than 150 minutes of a week exercise or moderate intensity exercises, or more than 75 minutes of inactive aerobic or anaerobic exercises. Patients should be advised. Those patients who are on the moderate or taking patients should also be encouraged for going for the resistant exercises as well, apart from only the moderate intensity or high intensity exercise, at least 2 days a week. That will impact its overall outcome. After the non-invasive or not.
Sorry, Dr. Bob, please summarize your presentation.
Okay, these are only a couple of last 2 slides only. I think only 2 to 3 slides, not more than that one. Okay, medical therapy, apart from pharmacological therapy, non-pharmacological, we all know that beta blockers, AC inhibitors, ARBs, aspirins, mineralocorticoid receptor antagonists that has already been discussed having a positive effect in the patients who are having a low ejection fraction of less than 40%, or having a arrhythmia, that having very good role. Immunization regarding the influenza COVID-19 vaccine is recommended also in the guidelines. Revascularization, on a single slide about the revascularization, it is recommended in those patients who are having despite GDMT, despite guideline-directed medical therapy, they remain symptomatic or having a complex 3VD or coronary artery disease. You can go for revascularization, otherwise medical therapy is recommended in these patients. I think so that's all I can say about that one. And I'm sorry if I take extra time of yours. And if you have any question, I welcome you all. Thank you.
Okay, thank you very much, Dr. Mahesh, Barbara. Thank you for your comprehensive talk with regarding the stratification of the coronary artery disease. You also include the comprehensive care about upstream therapy, hypertension, hyperlipidemia, and also nutrition, and to improve the patient care status. I think I appreciate your talk. Thank you. But time is up. I think we move to the next talk. If you have the time, we go back to Q&A. Thank you. So we will proceed. Next speaker. Let me introduce Dr. Kengo Kusano for the next talk. So Dr. Kusano is Vice President and Chief Director of Department of Cardiovascular Medicine, National Cerebral and Cardiovascular Center. So today he will give us a talk on primary prevention of sudden cardiac death in non-ischemic dilated cardiomyopathy, the genetic CMR, NT, and ICD. So Dr. Professor Kusano, please.
Thank you very much, Chair. So I'll share my slides.
Yes,
Can
please.
Can you see my slides? Okay.
Okay, thank you.
Okay. Yes, okay. Thank you, Chairman. So now we are behind the schedule. I'll make a quick presentation. So it's a great honor to make a presentation here. So today I want to talk about primary prevention in non-ischemic cardiomyopathy. So patients with non-ischemic cardiomyopathy are broad spectrum. The group of patients, including those with progressive and infiltrative forms of cardiomyopathies. So for this reason, the risk of developing ventricular tachycardia in non-ischemic cardiomyopathy is difficult to accurately predict or apply broadly to this group of patients. So here is here. The first major study on primary prevention is Scott-Heft trial. This trial, reported in 2005, demonstrated the importance of primary prophylactic ICD implantation in heart failure patients. Odds ratio was 0.77, that is to say, 23% mortality reduction. After this study, the importance of primary preventive ICD implantation was recognized. And at that time, so it has been shown that the difference in underlying cardiac diseases make a difference in the usefulness of ICDs. And that ICD implantation is more important in ischemic than non-ischemic heart disease. The difference is just very significant in non-ischemic cardiomyopathy. The Danish study reported in 2016 was a prospective randomized ICD-CRT study of non-ischemic cardiomyopathy. This Danish trial reported no survival benefit from prophylactic ICD implantation in the overall cohort, but ICD reduced sudden cardiac death to half, and subgroup analysis showed that in patients younger than 68 years old, survival was improved with an ICD. However, pooled analysis of 4 or 5 primary prevention trials, Definite, Scott-Heft, CAT, Amiobot, Companion, and Danish, revealed that ICD therapy was superior to medical therapy in all-cause mortality in patients with non-ischemic cardiomyopathy with decreased cardiac function. Yeah, so from this result, the guidelines for Europe, Japan, and United States has been proposed. So this slide is a class 1 indication. So based on the result of SCAT heft and other trial, the non-ischemic cardiomyopathy has adopted the LV, left ventricle ejection fraction, and New York Heart Association class. So in Japan, non-sustained VT is included, but basically, the same item. So last year, the ESC guideline was advanced to maybe reflect the result of the Danish trial. And the previously class 1 standard became class 2A. So ischemia and non-ischemic were clearly separated. So there are a couple of questions for primary ICD implantation for non-ischemic cardiomyopathy. First question is, so is indication evidence in Western countries applies to the patients from Asian patients, including Japan? And the second one is there any other markers beyond the left ventricle ejection fraction? So for example, cardiac MRI and pathogenic gene mutation, syncope, inducible VT by prognostic stimulation, and non-sustained VT. So about the first question. So recently we have published the result of Hinode study. So I'd like to show this result. The heart failure indication and sudden cardiac death prevention trial named Hinode was a prospective multi-center registry performed between 2017 to 2019. Total 345 patients from 34 hospitals were enrolled. There were 3 types of cohorts. So one is defibrillator cohort, and one is pacing cohort, and one is a non-device cohort. This slide shows patient groups. Among them, so all ICD and CRTD group items, a high voltage group were primary prevention, class 1 group in ESC guideline 2016. The correct data was compared with B plus C arm. So this is high rate only and prolonged detection programmed group. And the MADI-TREAT study, the incidence of ventricular events in B plus C arm was 10.2% per 2 year, around 5% per year. According to the MADI-TREAT study, the enrollment criteria was completely the same like this slide. And so I'd like to skip the detailed slide, but so the Kaplan-Meier result was shown here. So in the matched cohorts, the Kaplan-Meier estimates for the freedom from all-cause mortality and the first ventricular arrhythmia event were determined at 12 and 24 months follow-up. Propensity matched cohorts showed no difference in event rates. So this, the result of Hinode high voltage cohort revealed that the Japanese primary prevention patients, so it's Asian patients with heart failure background, have the same level of sudden cardiac risk seen in Western clinical science for ICD-CRT trials. The mortality and the ventricular arrhythmic event rates of landmark trials are applicable to patients with primary prevention in Japanese and Asian patients. The next clinical question of other markers beyond reduced cardiac function. So first, cardiac MRI. So it has been reported that the cardiac MRI for the definition of SCAR as rate gadolinium enhancement and potential substrate has emerged as a powerful risk stratification tool. This slide shows a systematic review and meta-analysis from 9 studies compared to the negative LZ rate gadolinium enhancement. The presence of LZE predicts more cardiac events, including all-cause mortality, heart failure hospitalization, and sudden cardiac death. Another review also reported LG was strongly and independently associated with ventricular arrhythmia or sudden cardiac death in dilated cardiomyopathy. So odds ratio were more than 10. So it's a very significant difference. This slide shows the importance of LZE location and patterns for later cardiac events. This paper indicates so in dilated cardiomyopathy, the presence of septal LZE is associated with large increase in the risk of death and sudden cardiac death events, even when the LG extension is small. So therefore, the MRI result has been growing importance for the risk stratification in non-ischemic cardiomyopathy. So next, gene mutation is also important issue for risk stratification. In the past decade, the importance of genetic mutations in various cardiomyopathies, so hypertrophic cardiomyopathy, dilated cardiomyopathy, ARVC, and left ventricular non-compaction has been reported. So especially in dilated cardiomyopathy, several gene mutations in sarcomere protein genes and desmosome genes has been reported. So now more than 30 genes have been identified as harboring mutations that cause a dilated cardiomyopathy. And the abnormalities involving sarcomere protein genes account for approximately 30% of cases of familial DCM. Laminopathy is a rare genetic disorder caused by mutations encoding proteins of the nuclear lamina. So this lamin ACG mutation causes isolated DCM and conduction system diseases. So this disease is found in late 1990s. Compared to the other gene mutations, LMNA gene mutation cases, the onset of symptoms is earlier and the mortality is quite high. So accordingly, early ICD management should be recommended. So typical symptoms are left ventricular dysfunction and conduction disturbance, so atrioventricular block, AV block, and ventricular arrhythmias. This slide shows a Japanese cohort, including our hospital. Truncation mutation has worse prognosis. And the conduction disturbance, so this is here, appears earliest, leading to left ventricular dysfunction and atrial arrhythmias and malignant ventricular arrhythmias. So most of them appears before 50 years old. Therefore, in patients with AV block and mild left ventricular dysfunction, laminopathy should be excluded using gene panel analysis. Next is inducible VT and the presence of non-sustained VT. This slide shows a usefulness EP study and non-sustained VT from 45 different studies. So this data reveals that the rule of programmed electrostimulation revealed inconsistent, but the existence of non-sustained VT has somehow better result. This slide shows a retrospective study of preceding non-sustained VT importance in patients with primary prevention of ICD patients. So both ischemic and non-ischemic cardiomyopathy. So this study is a small number, but non-ischemic cardiomyopathy patients with ICD, the preceding non-sustained VT would be a predictor of later ventricular tachycardia episode. These are the flowchart of each guidelines of ESC, AHA, and JCS. The latest ESC guideline is the most detailed ICD classification. MRI screening was first and considered genetic testing using medical history. After that, cardiac function and other risk markers. So syncope, LGE on cardiac MRI, indiscernible VT, pathogenic mutations considered as risk factors. But there were no class 1 indication in asymptomatic patients. AHA and JCS was similar, but JCS considered the presence of non-sustained VT, but not EP study. ESC and AHA guideline also shows the LMNA mutation laminopathy, even if left ventricular ejection fraction over 35%. So it's below 50%, ICD should be recommended as class 2A. So there's one more considering factor for primary preventive ICD implantation. This study was performed by the combination analysis using prospective studies, MADIT, MADIT2 definite, and SCAT-HEFT. The more comorbidities, smoking, CKD, diabetes, pulmonary disease, atrial fibrillation, peripheral artery diseases, the less benefit of ICD. So we should consider those comorbidities for ICD implantation of primary prevention. So in summary, ICD indication of Western countries can apply Asian and Japanese patients. Non-ischemic cardiomyopathy includes a diverse group from different etiology, but reduced cardiac function remains a powerful predictor of ventricular tachycardia and appropriate ICD therapy in these patients. The rule of cardiac MRI shows promise in some subsets. The results of EP study and non-sustained VT should be considered for the additional risk stratification. If suspicious laminopathy, so family history, and AV block in young age is below 50 years, genetic testing must be performed. Thank you for attention.
Thank you very much, Professor Kusano, for your nice comprehensive talk with regarding to dilated cardiomyopathy risk stratification. I think you provide a very important message that currently the stratification for ICD implantation not based on the LVEF. Currently, we have a lot of risk stratifier like the MRI, non-sustained VT, and genetic test. I think this is quite useful for risk stratification in patients with dilated cardiomyopathy. So only a short question. You have mentioned that in Japanese prospective study, also this is also the Western country, the data also applicable for the Asian Pacific country. Yeah. So do you think that the primary prevention is see from the duration Danish trial, the primary prevention is not so effective in patients with dilated cardiomyopathy? How do you see from the Asia Pacific country? From your Japanese data, is the same as the Western country, or do you think the revision of the Japanese guideline necessary as the ESC updated guideline?
Yeah, so after the study, so I changed my mind. So primary prevention guideline is adapted to the Asian and Japanese patients.
Yeah, okay. I think this is a very important message, and this
Right.
is a very update. Yeah.
Thank you very
Okay,
much.
thank you. So any other question from the panels?
Yeah, Dr. If I may ask, non-sustained VT seems to be more important than inducible VT in non-ischemic cardiomyopathy for risk stratification.
Yeah.
What type of monitoring do you recommend for non-sustained VT? What is good for you? A 24, 48-hour Holter, or these patches which go for 7 days, or are you aggressive to do an implantable loop record? A little bit thoughts on that from your side. Thank you.
Yeah. Yeah, it's very difficult. So it's so that's why HA and ESG guideline does not include non-sustained VT. so in Japan, so nothing described. Yeah, but also only so if you found the non-sustained VT, it's a true risk marker. So that's why.
Okay. Okay, thank you, Tani-san. So we thank you very much again for your comprehensive talk and nice talk about the DCM riskification. Dr. Kusano, thank you very much.
Thank you very much.
Okay, so we will go ahead to the next speaker. Next, we will invite Professor Ashish Nabar from India. So let me introduce Dr. Nabar first. So he's a consulting cardiology electrophysiology at Jupiter Hospital, and also he's from the Nabar Hospital, Mumbai. And today he will give us the talk of primary prevention and secondary prevention of sudden cardiac death in hypertrophic cardiomyopathy. I think this is also a very important issue. Risk stratification in adults versus pediatrics. Dr. Professor Nabar, please. Thank you.
Thank you. Thank you very much for a very kind introduction. Let me see if I can share my screen. Is that visible?
Sure, thank you. Go ahead.
And I'm audible well enough? Sure. So the topic for discussion given to me was discussing the primary and secondary prevention of sudden cardiac death in hypertrophic cardiomyopathy and compare how the risk stratification varies in adult versus pediatrics. At the outset, let me say I'm very glad to be in this August panel and as a part of the Asia Pacific Cloud webinar. Let's move on to the topic and let's see if I can move my screen. So hypertrophic cardiomyopathy has multiple phenotypic variants. The one on your left is a diffuse hypertrophy. The one on the right is a typical left ventricular outflow tract obstruction because of the asymmetric septal hypertrophy SAM, and you have even mid-ventricular obstructions. And there is always going to be a discussion if different phenotypes have different risks of sudden cardiac death. One thing is sure that early in the follow-up after the diagnosis, it is the sudden cardiac death which is the cause of death many a times. And as the follow-up gets longer, we are probably dealing with heart failure and atrial fibrillation-related stroke. What is actually the risk of sudden cardiac death depends on the population that you're looking at. If you ask the referral centers, they would quote a rate as high as 4 to 6% per year, but in a population, it might be about 1%. But still, it is higher than the risk of death in general population. So it is important to understand that hypertrophic cardiomyopathy certainly is associated with a risk of sudden cardiac death or a higher risk of sudden cardiac death. Now, these are the traditional major risk factors that we know, albeit with some qualification. A family history usually confined to a younger and a close relative. An unexplained syncope, which is relatively recent, so within 6 months. A wall thickness that is more than 30 millimeter, but we do understand that this is a continuous variable. So with every 5 millimeter increase in thickness, there is a doubling of risk of sudden cardiac death. A blunted response to exercise and a non-sustained VT recorded on a rhythm monitoring or ambulatory monitoring is also important, but we do have some difficulties in understanding what would be the definition of non-sustained VT. Well, if you look at it from the other end, do we know who is at a lower risk? And mind you, this is what we are talking about, an adult HCM patient. So if somebody does not have any of those 5 conventional risk factors that I talked about recently, and he has mild symptoms, or his left atrial diameter is less than 45, so not enlarged LA, LV wall thickness which is less than 20, and a less outflow tract gradient less than 50 millimeter, these are believed to be at low risk. Now, the recent advance has been the availability and a more wide use of MRI scan in doing a risk stratification for adult HCM patient. Probably because the MRI allows us to measure the LVH much more accurately in different regions of the left ventricle than what an echo does, and it is obviously not inhibited by the echo window. More important than that is the late gadolinium enhancement, which signifies the fibrosis. And lesser the fibrosis, we feel the safer the patient, whereas in fibrosis to the extent like this, 36% might mean that the risk of sudden cardiac death is very high. So LGE has lately become a very important consideration when risk stratifying sudden cardiac death. And asked me to put a number on the extent of sudden cardiac death. So many of the studies have used it as a binary variable, yes or no. But then it is probably also a continuous variable, or we do have some kind of a cutoff. And many studies have said that more than 15% of late gadolinium enhancement is some kind of a sacrosanct number to decide the cutoff for the risk of sudden cardiac death. Let's assume it to be true for a while. So how do we finally risk stratify adult HCM patients? Well, the Europeans would try to use the HCM risk SCD score, which is widely available online. And in addition to the traditional risk factors, they have included left atrial diameter and age to be keyed into that multi-parametric risk scoring system. And then you have it as a low risk, intermediate risk, or a high risk. And the SCD risk score in adults, mind you, does recommend whom to definitely give an ICD and whom you can avoid ICD. Coming to the American recommendations, they are a little more lenient. Even one of those major risk factors would qualify. Here, in addition, they have an apical aneurysm and a drop in ejection fraction as a major risk factor where an ICD can be directly considered. If you don't have any of these, then you have to rely on a non-sustained VT. And as I said some time back, extensive LG on the MR, CMR immediately makes you think of an ICD. If none of these are there, then probably you are good to not recommend an ICD. So there is this kind of understanding with the adult HCM patients. And I think most of us attending are quite familiar with these recommendations, both the American and the European. I participated as a document reviewer in this recommendation from the PACES, that is the Pediatric Cardiac Electrophysiology Society, and which was approved amongst all the international society, also by the Indian Heart Rhythm Society. And therefore, when our president CSI, Cardiology of Society of India, President Dr. Bang, requested me to take up this talk, I found that I could do it well. Let us see how we can discuss pediatric hypertrophic cardiomyopathy. I'm also interested in the pediatric electrophysiology. I attend this specific hospital in Mumbai, which does pediatric EP work. And I have participated a lot in sudden cardiac arrest or a CPR training program. So I have a lot of interest in discussing sudden cardiac death, this time more so in relation to hypertrophic cardiomyopathy. Now here we are switching gears to discuss pediatric hypertrophic cardiomyopathy. Now there are more than only sarcomeric causes of hypertrophic cardiomyopathy in childhood. These are the inborn errors of metabolism, rasopathies, neuromuscular diseases, and they are called as non-sarcomeric HCM. And they probably have a higher incidence of heart failure, but probably a lower incidence of sudden cardiac death as compared to the primary HCM. So one needs to make that diagnosis before one proceeds. The second thing to understand is that the risk of SCD in the pediatric patients is higher in the adolescent age group, something like 8 to 16 years. And this risk is definitely higher than the adults. The risk of sudden cardiac death in pediatric HCM is definitely higher in the adults, even if you look at a biased population or a population cohort. And most of these events occur in the first 10 years of diagnosis. So that might be 2 ICD devices. So it is important to have this context when one is discussing pediatric HCM. Coming to what we know of the major risk factors to give a ICD in a child with HCM, certainly if he has had a VFVT event, it is a no-brainer. He does deserve an ICD, although it might be difficult with the younger patients to make that decision. But otherwise, when it comes to primary prevention, the focus is on unexplained syncope, non-sustained VT, and extreme LVH. And if these are considered as major risk factors, then they have been included in the guidelines to decide the indication for an ICD in children. We have certain other risk factors which are considered as putative risk factors. So LA size has been lately considered as a reflection of restrictive physiology, and therefore it is important. And in fact, LV outflow tract gradient has a very contradicting relationship. There are some studies which show that increasing LVOT gradient is important to risk stratify sudden cardiac death, whereas actually some studies say it is actually an inverse relationship. So for example, an apical variant of HCM in children might be at a higher risk, unlike the knowledge that we have from adult HCM. So LVOTO might be protective. This might be a little controversial, but this is what is the state of knowledge. Now, there are some other risk factors. Family history, unlike in adult HCM, is supposed to be less important, or rather there is limited evidence. Age, we already discussed, adolescents are at a higher risk. And 12-lead ECG, we can better say that the various features that have been studied, there is only a moderate discriminatory value, and these are by and large not included in the guidelines. Late gadolinium enhancement on the MRI is proportional to the left ventricular hypertrophy, but only as an independent risk factor. In absence of prospective studies, we still have some doubts. Genotype sarcomeric mutation is important. Non-sarcomeric mutations are probably less important in risk stratification. So this knowledge about MRI and genotype is fluid, but some of that has been included in the guidelines. Now here is what the current recommendations for risk stratification sudden cardiac death recommending ICD are in childhood HCM. The ESC guidelines are a little stricter. They require at least 2 or more major risk factors, whereas the American guidelines have upgraded it to a single risk factor. So even if a single risk factor is present, the American guidelines do recommend a ICD. Now, apical aneurysm and an ejection fraction less than 50%, as we discussed some time back, are additional findings beyond the major risk factors that we outlined. So therefore, a event that has already happened, a resuscitated sudden cardiac death, VF or a documented VT are all definite indications. But primary prevention, American guidelines, only one risk factor is good enough. They have included the late gadolinium enhancement on CMR as the risk, but in terms of genotype, unless there is a phenotype only based on the genetic positivity, ICD is not recommended. So the American guidelines are actually the recent ones. Now coming to the results, if you were to implement these guidelines, patients who have received secondary prevention ICD, children who have received secondary prevention ICD based on these guidelines, almost 2/3 of them receive ICD therapy in 5 years. So it is definitely value for money. But look for the primary prevention results, and they are a little dismal, telling us that the state of the knowledge is still in its infancy. Only 2.5% children would receive an appropriate ICD therapy in first 5 years. And against that, you have to compare the problems that can be there by implanting the ICD in the small children, and they are not to be easily overlooked. So therefore, there is a certain pause that we must take and decide who certainly requires an ICD. Now, let us kind of understand in little bit detail as to why are these major risk factors also not performing that brilliantly when put in the guidelines. Now, let's discuss syncope. Now, the question is, how long ago was the syncope? If it is in 6 months, it is significant when you're risk stratifying an adult HCM. In pediatric cohorts, this is actually not well explored. And on top of that, you have a big difficulty in taking a history of syncope in clinical practice in a child. So therefore, there are these limitations, although it is a major risk factor. Non-sustained VT, I think I said a couple of times that we have not defined what non-sustained VT is significant. The frequency, rate, and length of NSVT that makes it significant is not defined. And as you see, that the exercise-induced arrhythmias is not a part of pediatric risk stratification. So are all NSVTs same? We have certain doubts. The most important discussion is about how to decide it is an extreme left ventricular hypertrophy. Now, where to measure the left ventricular hypertrophy? In the septum, in the posterior wall, or wherever it is maximum? Or should this ventricular hypertrophy be standardized to the LV internal dimension or to the body surface area, what is typically called as Z-score? So which left ventricular hypertrophy number is relevant? How do you measure the left ventricular hypertrophy on MRI, which is more accurate than echo? The Z-scores that are recommended can vary depending on what was the normative population on which you base the Z-score. Again, serial measurements of a left ventricular hypertrophy as the child grows might be more relevant. And is the risk linear or non-linear with left ventricular hypertrophy? So a lot of questions, even with this most important major risk factor when it comes to risk stratifying the HCM in children. LA enlargement is certainly important because it speaks of restrictive physiology, but LA can enlarge from MR, mitral regurgitation, or atrial myopathy, and therefore there is overlap. And certainly LA volume is better than LA diameter. So therefore, there is certain inaccuracy that comes in when you use LA diameter as one of the risk factor. Left ventricular outflow tract obstruction, as you must have seen, is actually not included in any of those guidelines, and the reasons are pretty obvious here. These are the cohorts which showed that even the lower gradients are suggestive of risk, and the higher gradients are actually protective. The risk is greater only in adolescents. The younger infants or the younger children seem to be protected by LVOTO. When should you measure the LVOTO? After adequate medical therapy, is it the residual LVOTO that is more determinant? And if LVOTO is proportional to the late gadolinium enhancement, is the late gadolinium enhancement more important? So again, there are a lot of questions with the left ventricular outflow tract obstruction, and therefore this probably is not even a part of the deciding criteria. Family history, we have said that we define it as 1 or 2 sudden cardiac deaths, younger patient, how a first degree relationship is probably what is a family history. But there are de novo mutations in children. So you may not have this kind of a family lineage that can be mapped. Again, sudden cardiac death in the younger children, their adult relations are yet young, and therefore sudden cardiac death may not have it happened. So you will get lesser numbers. And in fact, family history may be protective because these children you are going to follow up more closely and detect any deviation that would suggest the need for an ICD. So actually, family history is relevant, not relevant is again a discussion in childhood, in children, which probably is not at all in adult. In the interest of time, I will not say much on the ECG risk score because different ECG parameters have been studied. There is a feeling that higher the ECG risk score, less the freedom from sudden cardiac arrest. But the message to go home is that ECG is an excellent screening method. So you do not immediately start doing the ambulatory ECGs and the MRIs in every HCM patient, and therefore your first contact might be based on how the ECG and echo looks, and therefore a certain understanding of the ECG risk factors is important because it does tell you whom to screen further with more investigations. I think ECG risk score, we must leave on that. There is actually, it is never been a part of the guidelines. MRI, are there difficulties? Now, yes, MRI, the late gadolinium enhancement is proportional to the left ventricular hypertrophy, and probably it increases as the child grows. So that is an important thing. The late gadolinium enhancement, if you have to compare the two MRIs done prior and presently, it is possible that an increase in the LG might make you take a decision for an ICD. Whereas similarly, we are not sure. Most of the studies have used binary variable, that is LG is present or absent. But again, the extent of LG may be more important. And aneurysms, if they are picked up on the MRI, as I showed in one of my first slides, that would definitely then make them at a higher risk. So LG, we are gathering knowledge, and therefore I call it a moving target. But it is still not studied in prospective cohorts. Remember, this is an important thing. Most of the studies are observational and retrospective. We do not have it analyzed in a prospective cohort. Genotype again is a certain promise, but it is important to remember that if you have a non-sarcomeric kind of a mutation and no family history, these HCMs have a SCD mortality similar to the general population. If the sarcomeric mutation is there, then they are more at risk for sudden cardiac death than patients who do not have a sarcomeric mutation. And many a times the labs report a sarcomeric mutation as a variant of unknown significance. Even this comes between the sarcomeric positive and the sarcomeric negative group. So that is also important. And since the child is going to live longer, the ventricular arrhythmia risk is going to be there at multiple stages. So because of these difficulties, it has come to doing a multi-parametric risk score, which provides a 5-year SCD risk prediction, just like you have in adults. So you have HCM risk kids and you have primacy, 2 scores from 2 different continents. HCM risk kids. Now you have HCM risk score in adults, but it is not to be used for HCM patients below the age of 16 years. In fact, you are supposed to use HCM risk kid score. So after filling the basic demographics, and these are there mainly to calculate the Z score. So if you fill the demographics and you fill in the other parameters like the maximum wall thickness, mind you, it doesn't say ventricular septum or posterior wall. Wherever is the maximum wall thickness, the LA diameter in a parasternal long axis view, and these in fact here you can see that LV outflow tract gradient is included in this multi-parametric score. So once you fill in these 5 parameters, you will derive, and this risk score is available for free online. Once you fill in these parameters, you will have a risk estimate provided at 5 years. And similar to the adult, you can say that the risk of SCD is less than 4%, more than 6% in intermediate. But mind you, in children, the HCM SCD risk kid score does not recommend to put an ICD above 6%, because I think in children it is always a little bit what the parents say and what is your perception, and therefore the clinical decision making comes. So in this case, it is not recommended like in adults. But if you were to compare the observed and the predicted risk, SCD risk using the score, they are similar. So it is worthwhile using this, and therefore it is even endorsed by the European Society guidelines. The second American score, I must say, is the primacy score, which is again superior to the guidelines and similar to the HCM risk kits. And these are the number of things that you key in. Importantly, you can see here that you have both LVH in the septum as well as the posterior wall, and also the outflow tract gradient. But you can, if you have done a genotype, you can also key in that. And when you use that, the risk that is provided has a good risk prediction. That is that the concordance is more than 0.7, which is a good thing. And the improvement has come by adding the posterior wall and the genetic status to the algorithm. So primacy again is as good as HCM risk kits. And the suggestion is that both of them are superior to the guidelines that I mentioned some time ago. Once again, this score can also be easily available for free on the website. The primacy results of primacy were compared by using a cohort from the share, and it was found that primacy and cohort predict the SCD risk similarly in children. 1 year, 5 year, 10 year, the numbers are similar. Roughly, you can say 2.8 years, 9 year, 2.8%, 9%, and 15%. So these are the risks at 1 year, 5 year, and 10 year respectively, and they compare with the share cohort. So this primacy score has been validated using the risk score. So let me conclude here. I have presented what the adult and the childhood HCM risk stratification should be, and this might have clarified some things, but obviously must have raised a lot of questions in your mind. But let me sum it up by saying that the first step in the risk stratification is to look at the ECG and the echo. If the ECG risk score and the Z score based on the LV wall thickness is considered, you can divide the patient into low risk, intermediate risk, and a probable high risk. Having done this, it is the next step to do is to bring in an ambulatory ECG, and you can monitor for the presence of non-sustained VT or check if there is a family history of sudden cardiac death. Any one of them by the American criteria would make you think of an ICD. But if these don't total up, then you can better use the multi-parametric risk score like the HCM risk kits. And if it is more than 6%, then that is a high risk. But remember, the most important thing in children, which you can never put on a back burner, is what does the patient and the parent, what do they think about the whole scene, and what is the physician, what is his where is his bias? Does he think that ICD would really do good in this child? And then only you consider primary prevention ICD. So having survived a sudden cardiac arrest or documented a VT, it is no brainer that you need ICD. But primary prevention, I think all these parameters come into play before you can decide ICD. So how do I sum up? And I sum up based on what I did when I participated in the document. Survivor of sudden cardiac arrest, class 1 indication, even in a pediatric HCM to consider an ICD. If there is more than one primary risk factor, including syncope, hypertrophy, non-sustained VT, family history, then ICD placement is reasonable. What reasonable means is you discuss with the patient and the parent the complications, the potential complications, problems, effect on the lifestyle, and then come to that decision based on their perceptions. Also, if you may add an MRI scan on top of that if the LG is extensive. So probably we need some quantitative understanding of the enhancement. And if there's a systolic dysfunction, this will suddenly make you add those parameters to this and consider an ICD. In their absence, you would be a little still thoughtful. But having only a genotype positive without having a phenotype or without having a clinical diagnosis of HCM, genotype positive alone doesn't become an ICD criteria. I think this is what I will conclude at this point. And I think there must have been some clearing up of thought process, but certainly a lot of questions that this presentation might have raised. And we all as a panel, if we have time, can shortly discuss it. Thank you very much for this invitation, and thank you for your patient listening.
Thank you very much, Professor Ashish and Nabar, for your nice comprehensive talk. We got the stratification of the hypertrophic cardiomyopathy in adult and pediatric. I think the content is quite clear and make us a very good introduction for the risk stratification of this patient. Thank you very much. Because time is up, so we have to move to the next speaker. If we still have time, we can have a final panel discussion in the end. So thank you very much. The last, but not the least, so I would like to introduce our last speaker from Thailand. So the Dr. Pattarapong. He's an associate professor of the cardiology department of medicine, Khurelbaatar, the University of Thailand. He also is a director of the King Sirikit Heart Center of the Northeast Thailand. So today he will give us a talk of the stratification and prevention of sudden cardiac death in primary electric disease in Asia-Pacific region, Khurelbaatar, non-QT, and CVVT. I think this is also a very important topic in the Asia-Pacific region. Thank you. So, Professor, please, thank you.
Okay, thank you. Thank you so much for giving me opportunity to talking about this very interesting topic. Can you see my slide now?
Okay, sure. Go ahead. Thank you.
Okay. Thank you. Thank you for APSC for giving me my opportunity to present this topic. The topic about risk stratification and prevention of sudden cardiac death in primary electrical disease in Asia Pacific. So first thing we have to know about when we're talking about the ventricular arrhythmia and sudden cardiac death in common primary electrical disorder. The meaning is in the genetic channelopathy is the same thing. And the common genetic channelopathy, I think we have 4 conditions now that very common in practice now. First one is a long QT syndrome. The second one is a Brugada syndrome. The third one is we call CPVT, catecholaminergic polymorphic VT. And another important disease that sometimes if we don't pay attention after the patient has syncope or has his family history of sudden cardiac death in the family is the early repolarization syndrome, because this pattern about the early repolarization pattern, if we don't make attention to see the ECG, sometimes we miss. So I want to share something about this case. If we see this patient, 22 years old male, present with recurrent syncope during playing football. The echocardiogram is normal. The ELV ejection fraction is preserved. And we set the Holter to investigate what is the cause of syncope in these patients. And this is the result of the Holter that's sent back to me. And when we looking into the review the Holter, this is the the thing that the Holter monitor show before the patient have syncope and the record ECG when syncope is like the torsade de poor. So what do you think if you see the patient like this? What is the most likely diagnosis? CPVT, long QT syndrome, early lipolysation syndrome, Bucada syndrome, or idiopathic VF. So when we're looking into the Holter again, this is a torsade de poor. And after torsade de poor, they turn to the ventricular fibrillation and patient have syncope. And this is the ECG that we're looking before the event of torsade de poor happened in the Holter. What do you think? You get something from this ECG? First thing, we have QTC is very prolonged. Collected QTC is prolonged. And we have something we call macroscopic T-wave alternate. And T-wave alternate is something like precursor to cause the arrhythmia we call the torsade de poor. So in this patient, we can diagnose as the patient have long QT syndrome because this is a recommendation from APSC to diagnosis of the long QT syndrome. The long QT syndrome can diagnose with either the collected QTC is more than 480 milliseconds in repeated 12-lead ECG with or without symptom. This is the first thing we can diagnose by repeated ECG and QTC is prolonged. Another thing that we can make diagnosis of long QT syndrome, we use a long QT syndrome diagnostic score. And if we score more than 3, we can diagnose a long QT syndrome. About the genetic testing can diagnose the long QT syndrome. If the patient send the genetic testing and the result come back as the present of pathogenic mutation, if the pathogenic mutation of long QT present, we can diagnose long QT syndrome irrespective of the QT duration. So we can diagnose long QT syndrome by 2 methods, repeated ECG or pathogenic mutation of the long QT syndrome. And this is a thing that I call the risk score for long QT. So if we're looking into our patient, the QTC duration is very prolonged. So we give the 0.3. The patient have torsade de poor, we give the 0.2. The patient have T-wave alternate, we give the 0.1. And the patient have syncope with during pre-fitbone with state, we give the 0.2. So in this patient, we make the score equal to 8. So we can diagnose a long QT syndrome by risk score. And this is the thing if we want to make the risk stratification in long QT syndrome. Definitely, if the QTC is very long, like more than 500 milliseconds on repeat ECG, this is a very high probability of long QT syndrome diagnosis. If we want to confirmation, we can send genetic testing. But if we calculate long QT risk score, if the risk score is less than or equal to 1, he is very low probability to diagnose long QT syndrome. If long QT syndrome risk score is equal or more than 3.5, is high probability of diagnosis long QT syndrome. So if the score is intermediate, we call the intermediate probability. This is a flow chart to diagnosis long QT syndrome by QTC and long QT risk score. Now from the European Society of Cardiology, they have the new, we call modified long QT diagnosis score. If you're looking into the detail of the score, it's quite the same. But the thing that APSC put into the modified long QT diagnosis score is the genetic mutation. So if you see in this graph, if you find pathogenic mutation, they give 3.5 points. And if the modified risk score more than 3, you can diagnose a long QT syndrome. So if you use this modified score, if you send genetic testing and the genetic testing come back, show that the patient have pathogenic mutation for long QT syndrome. So you can diagnose long QT syndrome irrespective of the long QTC duration. So the thing you have to know about the information about genetic of long QT syndrome, because the common type of long QT syndrome is long QT1. You have defect in IKS. Long QT2, you have defect in HERG gene or IKR. For the long QT3, you have the defect or gain of function of the SCN5A mutation is gain of sodium function. It's very difficult, different from the Bucada syndrome, because Bucada syndrome is some disease that has a SCN5A mutation, but Bucada syndrome is a SCN5A defect, but long QT syndrome is a gain of SCN5A mutation. And if you see the ECG pattern of the patient present with long QT syndrome, you can make something that you can predict genotype of the long QT long QT syndrome by looking into the ECG. If you see the ECG is a long QT with bi-wide based T wave, this is suggest of long QT type 1. If you see long QT with bifid T wave, this is suggestive of long QT type 2. If you see the ECG have very long state ST segment, this is a ECG that suggests a long QT type 3. So in terms of management, we have to give the general recommendation to prevent sudden cardiac death in patients with long QT syndrome. First thing is to give the patient to avoid the QT prolonging ducts and avoid and correct electrolyte abnormality that can cause long QT, such as correct hypokalemia, correct hypocalcemia, correct hypomagnesemia. And the very important things to prevent sudden cardiac death in long QT syndrome, because long QT syndrome, sometimes we have the genotype specific trigger for arrhythmia. For example, long QT type 1, the specific trigger is the exercise. So if the patient have long QT1, you have to advise about the sport, about the exercise, about the heavy exercise. If the patient have long QT type 2, the specific trigger is about the auditory. So you have to make the patients about the postpartum period, about the auditory trigger to recommend the patient to avoid the specific trigger things. The same thing for all the long QT syndrome, we have to give the beta blocker. And the beta blocker for the long QT syndrome is different from the heart failure with reduced EF, because a beta blocker for use for prevent symptoms and prevent sudden death in long QT syndrome. Ideally, we use a non-selective beta blocker, nadolol or propranolol. This is a two beta blocker that we recommend in long QT syndrome patient. And for the long QT3, we know that long QT3 have the gain of function of SN5A. So they have the hyperfunction or very more function of the sodium channel. So maxilitine, Lido, anti-arrhythmic drug class 1B, it can block sodium channel. So maxilitine can use in long QT3 patients with prolonged QT interval. So this is a medication that we use to prevent sudden death in long QT syndrome patients. In terms of ICD implantation, we only use ICD implantation in the long QT syndrome who have history of survival of cardiac death. And every time you use the ICD to prevent sudden death, you have to give the long QT syndrome patient the beta blocker, because the ICD implantation used for prevent the patient death from recurrent arrhythmia, but you have to give the beta blocker to prevent the new episode of arrhythmia. This is a really important thing. So when you give the beta blocker like nadolol and propranolol, you have to follow up the QTC in the patients, and especially if the patient have long QT1. When you follow up the QTC, you have to follow up when the patient have specific trigger like evaluated by the exercise state test to see after the patient get the beta blocker, the QTC is not prolonged enough to cause the event when the patient have exercise. So if we're looking into another risk stratification that now we use a lot in long QT syndrome, because long QT syndrome is an associated arrhythmic event with the genotype. Now we can use that we call 1, 2, 3 long QT risk score. This is to predict the arrhythmic event list in the patient who have the long QT syndrome. If the patient have high risk feature based on genotype and QTC, we can give ICD implantation as the class 2B indication in this group of patients. So I think another disease that very important in Asia Pacific is a patient like this. This is a 36 years old male, and this is an ECG after cardiac arrest. So if we are all cardiologists or internal medicine, or sometimes you are general practitioner, if you see this ECG in the younger age, echo is normal, angiogram is normal. This is we call the ECG that we call the COV type or type 1 Munkhtulga ECG. The characteristic of the COV type or type 1 Munkhtulga ECG is the pseudo light band block pattern with ST elevation in V1 and V2. So the important things you have to think about the ECG diagnostics of Munkhtulga syndrome is you have to document the COV type or type 1 for diagnosis of Munkhtulga syndrome. If you have the patient have type 2 or type T, you have to make something to make type 2 or type T challenge that they come to type 1 or not. By the first thing we can do this. This is the original ECG from the first presentation of Professor Joseph Bugada and Petro Bugada from 1992. And this is the prevalence of Bugada syndrome. I think this is the prevalence that we study in Thailand. For my paper that I present in Journal Arrhythmia in 2015, we see the prevalence of Bugada syndrome is 1.8% if you're looking into the high intercostal space lead ECG. And another paper from Thailand, Dr. Ratanawong report the prevalence of Bugada syndrome in Thailand is higher prevalence if the patient is record ECG by high intercostal lead space ECG, and if the patient have acute febrile illness, they can provoke the Bugada ECG. So the prevalence of Bugada ECG in the patient who have acute febrile illness and we record the ECG by high intercostal lead is about 4%. How about the genetic testing for SCN5A gene? The recommendation now from the ESC guideline, genetic testing only used to examine in the patient who is definitely diagnosis of Bugada syndrome by surface ECG. In terms of stratification, maybe sometimes controversy, but if the genetic is positive, maybe we have some advice to their family history. So, what do we have the evidence of prevalence of SCN5A mutation in Asia Pacific? Because the SCN5A mutation, pathogenic SCN5A mutation is higher in European Life Priority report, around 22%. But in Thailand, we report around 6% of SCN5A mutation, and another paper from Japan, they find SCN5A mutation around 10%. So in the prevalence of SCN5A in Bugada syndrome, we found that prevalence of pathogenic SCN5A is in Asia Pacific is lower than we found in European or in US country. This is the way why we call high intercostal lead ECG, because when we use high intercostal lead ECG, they can record ECG in the area of alveolar tract. So we can manifest the concealed Bugada syndrome to manifest Bugada syndrome. Or if you don't use a high intercostal lead, or you use high intercostal lead combined with the medication that block sodium channel like ashmaline, flecainide, they can bring out the pattern of Bugada Taiwan. And this is a paper from me and our team from Thailand collaborate with Mayo Clinic in US. So this is we call the PAS score or predict arrhythmic event or PAS score, because we have problems which patient with Bugada syndrome can have arrhythmic event. So this PAS score, if the PAS score is more than 10, from TPIC to TN arrhythmic event, PI12 is prolonged AVR sign, fragmented QRS or early lipo pattern. If you have score or PAS score more than 10, this is can predict first arrhythmic event, like sensitivity is around 95% and specificity is around 90%. So this is a new score that we published in Harlem this year. For recommendation, we recommend ICD in the patient who have history of sudden cardiac death. And in terms of general recommendation, we have to recommend all these three things to every Bugada syndrome patient to avoid of sudden cardiac death. First thing, we have to avoid the drug that may induce sodium channel blocker, because this is we can find by bugada.org, because if you use drug like sodium channel blocker, they can manifest the Bugada syndrome and precipitate the arrhythmia. Second, you have to avoid the cocaine, cannabis, or excessive alcohol intakes and high glycemic index diet. The third thing, we know that fever can precipitate Bugada syndrome and cause more arrhythmia. So if the Bugada syndrome patient have fever, you have to treat with antipyretic drugs to relieve the fevers. And this is my paper that I think published maybe 15 years ago. I found that the effect of high glycemic index after the patient eat very high glycemic index, the STG change is happen around 1 hour and 1.5 hours. So this is the pattern of the ECG. If you have the high fever or high temperature, the ECG will make more cough time and make more arrhythmogenic event in high fever. And another thing, after you put the ICD in the Bugada syndrome patient and you see something like this from the ICD interrogation, this patient have recurrent of the event. And this is my paper that published in Journal of Arrhythmia and Singapore medical journal. We found that for the Buccal syndrome who put the ICD for secondary prevention, the recurrent rate of arrhythmia is around 1/3 at 17 months follow-up. So very high prevalence of recurrent ICD shock. So this is a mechanism why the patient have Buccal syndrome have a lot of arrhythmic event, because of now we believe the Buccal syndrome have abnormal of the increase transient outward potassium current, decrease of sodium channel, decrease of calcium channel. And another thing we think Buccal syndrome have some fragmentation or substate at RV alpha region. So this is a pharmacological treatment for treatment in the patient who have inappropriate shock. We use quinidine because quinidine can block the transient outward current and it can reverse the pathophysiology of the Buccal syndrome. And another thing is very important. If the patient of Buccal syndrome has electrical storm from recurrent ICD shock, the medication of choice after we rule out the ischemia is the isoproterenol, because isopel or isoproterenol can increase the calcium in the cell and can stop the electrical storm in Buccal syndrome patient. Another disease that I think very important, this is for recommendation about the Buccal syndrome that I talk. Another disease that I think very important is this one. This is a 28 years old male post defibrillation. If you're looking into the ECG, you see that the patient have very quite big J wave. So if you see something like that, big J wave in inferolaterally, and you're looking into the V1, V2, maybe it look like the cove type of Buccal syndrome. This patient have the early lipo syndrome. And if you have the early lipo syndrome in the inferolaterally, and you look into V1 and V2, you see the Buccal pattern. This is we call global J-wave syndrome. This is a very high list of the list of sudden cardiac death. This is if you have bigger of the J-wave, this is like the substrate to cause the polymorphic VT in phase 2 re-entry. I think the final disease that we see quite often in Asia Pacific, and I see a lot of cases come back to see me in every year, is a patient like this. 16 years old male present with cardiac arrest, and this is the ECG. If you're looking into this ECG, you see something that very typical. This is a we call CPVT. The CPVT, after they convert to the baseline ECG must be normal. No abnormal of QTC, no abnormal of PI interval, no abnormal SSC segment. Baseline ECG must be normal. This is a CPVT. CPVT is an autosomal dominant. It has a genetic heterogeneous. It happens during exercise and emotion. The keyword is the baseline ECG is normal, and the ECG during the symptoms is a bidirectional VT. So in the management of the CPVT, to prevent sudden cardiac death, we have to recommend about genetic testing. And if the patient have genetic testing or have the symptom and have the PVC such as the bidirectional VT, we have to give the medication. This is the characteristic of the bidirectional VT in lead 2. You see, this is a like upper, lower, upper, and lower. We call ping pong effect. The patient who had the CPVT have the characteristic of exercise-induced bidirectional VT. This is a disease of the calcium overload in the cell by leaky of the lionary receptor and cause the more calcium in the cell, calcium overload in diastolic phase. And this is a delay after activity, trigger activity. So the medication that can stop this calcium overload have two medications. First is beta blocker. Beta blocker have the same as a long QT syndrome, nadolol and propranolol. And second thing, we can use the flecainide. Flecainide is a class 1C anti-arrhythmic medication. The effect of flecainide can stabilize the leaky of RY/R2 channel. So it's a channel stabilizer, so can treat the CPVT. And this is another ECG of my patient who had the CPVT. You see, this is a CPVT. So recommendation for prevention death, you have to give the beta blocker. If beta blocker could not control the symptom, you can add flecainide. ICD is reserved only the CPVT patient who have history of sudden cardiac death only. This is the new recommendation for CPVT. So in my final word, I think if you see the bidirectional VT, the disease that you have to do think about the 5 differentiation. First thing common is formic intoxication, CPVT, Anderson-Tawil syndrome, long QT7, toxin form acronite poisoning, or fulminant myocarditis. This is only five conditions that can cause typical ECG of bidirectional VT. This is the diagnosis criteria of Anderson-Tawil syndrome. So in conclusion, I think we're talking about how to prevent sudden cardiac death in the patient who have the genetic Khurelbaatar. The common have for disease, long QT syndrome. You have to advise about long QT medication. You have to give beta blocker like nadolol or propranolol. Munkhtulga syndrome, you have to advise about sodium, avoid about sodium channel blocking medication, avoid about fever because a fever can precipitate, avoid cocaine, cannabis, and high gastric index. CPVT, you have the beta blocker and ficanide. Thank you so much. This is my final slide.
Okay, thank you very much. Yeah. So any questions from our audience or from the panel? Okay, so I think Dr. Pattarapong just provide a very comprehensive talk with regarding the risk regression in patients with electric disease such as the long QT, Bugada, in early reparation, also CPVT. I think this is a very comprehensive talk and give us an introduction to prevent and stratification of this patient. Thank you. So finally, I'd like to invite Professor Lin Junli, our course director of this event, to give us a closing remark.
Thank you for Professor Yenn-Jiang's very inventive chairing auto section. It's my very pleasure to have the Professor Yenn-Jiang's help to support the whole section because of the sudden absence of Dr. Mungun-Ulzii because of his admission to the hospital. First of all, from the whole section, we can notice that the Dr. Gantulga talk about the acute coronary syndrome and how to prevent sudden cardiac death early and late after the myocardial infarction, and he's talking about the lack of guidelines to talk about how to implant the ICD to whom we need. And that's the difficulty for acute coronary syndrome, although the sudden cardiac death rate is much better after the PCI intervention. Second talk about the chronic coronary syndrome by Dr. Mahesh, Kumar, Batra. He has been presenting a lot about the chronic coronary syndrome in addition to the prevention of the sudden cardiac death for those patients with LVEF more than 40%. He's talking very much about integration of the treatment about the hypertension, lipid, and also the hypoglycemia, and also heart failure treatment in these patients so as to prevent the sudden cardiac death. These patients. And the talk by Dr. Kengo, Kusano, he has been putting about the prevention of sudden cardiac death in primary cardiomyopathy, so those with dilated non-ischemic cardiomyopathy. He's talking very much about the difficulty in preventing the cardiac death because all the guidelines from Europe, from America, it seems that it's applicable to Asian people, but not really so effective as we really impressed from the Denmark study. But that's also the difficulty that we are facing in these patients. But we will learn a lot. We have more guideline-directed medical therapy for the heart failure. Maybe we improve on that in addition to the ICD use. And the important talk from Dr. Ashish Nabar talking about the hypertrophic cardiomyopathy. He is talking very much impressively about the pediatric guidelines for the hypertrophic cardiomyopathy prevention. It's really important because this part is really not really familiar for adult cardiac. It's an electrophysiologist, but he's talking very much about the score and also the risk score from Europe, and talking about the very unusual situation of the we alpha obstruction is severe enough. Actually, it's improving the outcome of these patients. And he's talking about the most risk is coming for those in those patients about the 8 to 15 years old. That's the age that can have more sudden cardiac death in pediatric hypertrophic cardiomyopathy. Lastly, that's the Pattarapong, Makarawate, talking about all the situation of these inherited arrhythmopathy in Asian Pacific regions, especially about long QT syndrome and also the Khurelbaatar syndrome, the most popular in Asia Pacific, and also the CPVT and also JV syndrome. All these primary electrical illness has been pretty much understood by all the cardiologists in Asia Pacific, but we are learning a lot how to differentiate from the daily activity. Thank you all for the great contribution to this very difficult web conference talking about the silent cardiac death. As we know that this topic is still going on and we are still learning every day, and hope that the more and more knowledge coming out will be more and more smart handle this patient. Thank you. Thank you for all the chairpersons and also the speakers for this excellent web conference. Thank you all for your contribution to this section. Thank you all. I will say goodbye here. Yeah. Okay. Goodbye.
Thank you.
Thank you.
Thank you. Thank you all.
Thank
We
you.
will close the
everyone.
section. Thank
Bye,
you.
everybody.
Thank you.
All the
Yeah.
panelists.
Bye-bye.